So with that, we'll go ahead. We're going to have our first presentation of session 2 from Dr. Caroline Robert from Institut Roussy, followed by melanoma neoadjuvant therapy with kinase inhibitor presentation from Dr. Jennifer Wargo from MD Anderson Cancer Center. And finally, last presentation for the session 2 will be from Dr. Janice Taub on pathologic response criteria in melanoma from Johns Hopkins University. Dr. Robert.
Thank you. Good morning, everybody. I think it was quite interesting, this session, and it shows us how we are in the same world, but at the same time in different worlds. And I think it's we can learn from each other, but we really have to acknowledge the differences in terms of approaches, in terms of therapeutic approaches. So if we go back to melanoma, after my disclosures here, Suzanne has made such a good introduction that I can go really quickly. It's true that the concept of neoadjuvant immunotherapy relies on the fact that we might induce a more robust immune response if we give the treatment, the immunotherapy treatment, when we still have a big size tumor. But the theory could be challenged by the fact that if we want to be useful, it implies that we might have some microscopic tumors still in the patients, and we could think that it could be enough because there are still some tumor antigens. But the reality, and it seems to be more and more, we have more and more evidence for that, that indeed it's better to have a bigger tumor size when we initiate the treatment. And the goal is not to reduce the size of the tumor, because we even know that sometimes we might initially increase it. It's not to have an easier surgery, as it could have been for other chemotherapy or targeted agents treatment. It's really to have a more robust immune response. And so that when we finally take off the tumor, and maybe, who knows, maybe one day we'll not take it off, because we won't need, but then we will have less microscopic tumor that will be able to wake up and to grow. Okay. In fact, if you look at the preclinical models, you don't find that many convincing papers that tell you that a neoadjuvant immunotherapy is better than an adjuvant treatment. And the best one is really this paper that already Suzanne presented, where it's not melanoma, it's breast cancer, back to breast models, but it's very, once that you work with a cell line, you don't even really know what's left of the initial tumor. Anyway, 41 model that is widely used, and another model. So these are metastatic models where there is a big tumor, a big primary tumor, and then we know that these mice also have metastatic disease. And the neoadjuvant immunotherapy in this paper is Treg depletion associated with an anti-PD-1 or an antibody which is an agonist or 4-1BB. And in this paper, it's very nicely demonstrated that when you do the surgery after the treatment, and it works in the 2 types of model, but a little bit better when it's associated with the CD137 agonist antibody, you really see that you have a more robust immune response, and you see more CD8 positive T cells in the blood and in the tumor when the surgery is done after the treatment, and you also see that the mice live longer. But in fact, you don't have that many papers. So let's go to see what we have in patients. If you type in clinicaltrial.gov, you put melanoma neoadjuvant, 58 trials. 10 active, not recruiting, so they are still getting data, but they are finished for the recruitment, 12 actively recruiting, and 6 trials that are not yet recruiting. If we look at that in detail, for the active non-recruiting trials, you see here, most of them are phase 2 trials, small number of patients, except the TVEC trial that I'm going to tell you about a little bit later. Most of them involve patients in stage 3 disease. We have a trial that is very special, very different for lentigo malignant melanoma. It's actually a French trial where the immunotherapy is a topical immunotherapy, TLR agonist that is in a cream formulation, imiquimod, that is applied on the lentigo malignant melanoma to try to decrease the margin. So if we take that off, you see that we have, out of 8 trials, we have 5 of them that include an immunotherapy. We still have 3 trials with targeted agents, dabrafenib, the first one, vemucobid, the second one, and axitinib, the last one. Look at the first endpoint. So there are, of course, secondary endpoints, but let's look at the first endpoint. We have pathologic response, so not always PAT here, but pathology response at the first endpoint for the first, the third, and radiological response for the last one. So these trials, we are going to have the results. For some of them, we already have the results. What do we see if we go forward and we look at the trials that are actively enrolling patients right now? We still have mostly phase 2 trials. We have increasing number of patients, and we have an increasing number of trials with immunotherapy as compared with targeted therapy. You see there is only 1 trial with targeted therapy at the bottom, which is actually evaluating how the adjuvant dabrafenib combination will do with regards to the initial pathological response. But all the other trials are immunotherapy based. Most of them have an anti-PD-1 or an anti-PD-L1. Most of them are related to patients with stage 3, but you have some trials that begin to get interested into earlier disease, the first one and the second one. And if you look at the endpoint, it's more and more trials that are looking at the response in terms of pathological response, or for the first 2, it's not really called pathological response, but it really comes back to the same thing because it's biomarkers in the sentinel node or rate of positive sentinel node. If you look at the trials that are planned but not yet recruiting, that are going to be initiated if everything goes well, still very early phase trials, phase 1 and 2. All are immunotherapy based. All have an anti-PD-1 or an anti-PD-L1. And all except one that Christian might tell us about have as a first endpoint pathological response. So it's interesting to see that even though we have nothing standardized, we have nothing authorized, we tend to go towards the use of immunotherapy in the neoadjuvant setting, and towards the use of pathological response as the main endpoint. Just to give you some information of, I think, what should be the good examples to follow, we have some trials that have been published recently. This one, Tara, who is here, can tell us much more about it. I think it's very instructive. This has been published in Nature Medicine very recently. It's 1 single dose of pembrolizumab in patients with stage 3 or 4 resectable. And in these patients, about 1/3 had a very good pathological response, complete or near complete. And it was associated with a very good outcome in terms of relapse-free survival. These patients did not relapse. And what I think is really needs to be acknowledged as really an example to follow is that the patients have been really studied in detail from the translational research point of view, with not only in the tumor but also in the blood. And it's very interesting to see that very early on, there are some signals of activation in the blood, earlier than in the tumor. And that comes back to what Suzanne told us at the beginning. What are the mechanisms? Are these cells initiated in the lymph node and then go in the blood? Or are they recruited? I mean, obviously, they might be recruited from the blood to the tumor at some point. I think it's very instructive for us, and I was actually surprised to see this kind of response. It's like opening our eyes on something that we do all the time in the metastatic disease, and we have a sort of open window of what happens in the tumors. We have listened to this presentation by Reinhard Dummer at the last ESMO meeting with the TVEC neoadjuvant treatment. So here, from the methodologic point of view, it was a little bit criticized. It's a large trial. It's a randomized trial with 150 patients. And you see that the time before the surgery was very different in the two arms, because in first arm, you have 6 injections in the tumor of the TVEC, the virus, oncolytic virus. And in the other arm, you don't have this injection. So the surgery is done right away. And just to go very quickly, a good pathological response in about 15 to 20% of the patients. Patients do better in terms of relapse-free survival if they have a good response. But here, the post-surgery treatment was not controlled, different type of adjuvant treatment, so it's difficult to really analyze very well. I think it's interesting, but probably we don't get the maximum information of what we could with this trial. These two trials, so I put them after, although they have been published before the one with pembrolizumab single agent, just because I wanted to follow monotherapy and then combination. So here it's combination, ipi/nivo. So we have Christian and Jen here who can give you much more detail about that. On the left, Christian trial, adjuvant versus neoadjuvant of the combination ipi/nivo, with for the first arm, the drug was given after the surgery, and the second arm, there were 2 infusions of ipi/nivo before and 2 afterwards. And in Jennifer trial, it was a combination of nivo or nivo plus ipi in neoadjuvant setting. And here, I don't have a lot of time, and I think you have read this paper in Nature Medicine. Although I think it was totally exemplary in terms of translational research, a lot of effort, very high technology of immunomonitoring. We see that with the combination ipi/nivo, we had more immune response at the level of the clone that were found in the tumors, and better outcome in terms of pathological response with the combination of ipi/nivo. However, a lot of toxicity, unacceptable toxicity in terms of grade 3 and 4 adverse events. You see the rates, and that's why more recently, and also published in Nature Medicine, I think, Lancet Oncology, in search of the optimal neoadjuvant regimen with the Opacine Neo trial. And Suzanne told us about these 3 arms. And finally, the winner is the arm B, with 2 infusions of ipi/nivo at a reduced dose of ipilimumab of 1 milligram plus nivo 3. Seems to be very tolerable and not to lose any efficacy. And you see here again the flatness of the curve when you obtain a good pathological response. So I think we're getting close, at least with the combination of the immune checkpoint inhibitor. Janice is going to tell us about that. I wanted also to speak, but we couldn't have enough time, because I think we are really not talking about the same thing with the breast people. I think it's totally different. I mean, we evaluate the patient in a different way with immunotherapy than we did with other drugs. So it's not surprising that the response, the pathological response, means something totally different. And I think I understand very well that it could be very useful to readjust the treatment when you look at the pathologic response in breast cancer that you treat with chemo or with whatever treatment, which is not immunotherapy. But from my point of view, if I read well, there is no correlation with overall survival, which we really hope that we will have with immunotherapy. So I think it's very different. I think we have to continue to work on this difference to understand better. And with that, I would like to conclude and to say that the concept of neoadjuvant immunotherapy for melanoma is very convincing. It's highly promising, and I think we should begin to consider that in the earlier stages also. And it's not my effort that are low for that to talk to my industry colleague to try to convince them to do a trial in an earlier stage, and they will recognize themselves in the room, I think. We see that we have mostly anti-PD-1 based right now, but we need to evaluate other immunotherapy. And I think we should work a lot on the place of intratumor immunotherapy in this setting. We do a lot of intratumor immunotherapy in the metastatic setting, but I believe much more in intratumoral immunotherapy in this neoadjuvant setting. We have, for example, a trial where we inject ipilimumab intra the tumor in the metastasis, and I think we should try to combine EP in the tumor in the neoadjuvant setting plus Nivo maybe in the tumor or systemically to try to reduce the toxicity and to still have a good efficacy. And pathological response, which I think is totally different in this context and in the other context. Thank you very much.
My name is Jen Wargo, and it's a great honor to be here. I'd like to thank the FDA as well as the MRA for the kind invitation to present our work. And shout out to Suzanne Topalian, too, for helping to organize this and for all her efforts in the field. And so today I wanted to talk a little bit about melanoma neoadjuvant therapy with kinase inhibitors and share our experience. And so I do have a few disclosures. And I wanted to start off with a case example. And this was a patient that Rhoda, Maria, and I treated 6 years ago when I actually had just joined MD Anderson. And so this is a 45-year-old female with a prior history of a right arm melanoma who actually presented to MD Anderson in October of 2013. She had bulky lymphadenopathy in her right axilla, which was considered unresectable at the time. She was actually told by an outside oncologist that she could be offered palliative radiation, but thankfully came to us and had a biopsy and was noted to have a BRAF V600E mutation. We treated this patient. You can see that she has bulky lymphadenopathy there with an extensive viable tumor. We treated her with neoadjuvant BRAF and MEK inhibitors, and we did restaging, which actually showed a complete radiographic response. I took her to surgery and did a complete lymph node dissection on her, and what we found at the time was that she had actually no viable tumor after just 8 weeks of therapy. And this patient is alive, well, and free of disease 6 years later. So pretty remarkable. I mean, I think we've made tremendous advances. And Suzanne already highlighted this, but I think it's good to revisit this. You know, we've certainly made huge advances in the treatment of melanoma and other cancers through the use of targeted therapy and immunotherapy. This slide is I borrowed from Georgina Long, and this really kind of shows a timeline and how much progress we've really made. And so we know that along with all these approved agents, we've now doubled and tripled the 1-year survival rates for patients with advanced stage disease. And furthermore, these agents are now being used successfully across the spectrum of disease, alone or in combination with other strategies, and also in other cancer types. Now, this does, of course, include the use of targeted therapy and immunotherapy in the adjuvant setting, and we are all familiar with this data showing a survival benefit when these agents are used in the adjuvant setting after successful surgical resection. But there is a very strong rationale to use this in the pre-surgical or neoadjuvant space. And we know that, as a surgeon, I know that the limitations of surgery itself, I know that if I take a patient straight to surgery with bulky stage 3 melanoma, many of those patients will relapse, especially before the era of the use of adjuvant therapy. And in addition to that, we've already heard the elegant work that was presented showing the potential benefit of using neoadjuvant versus adjuvant, particularly with the use of immunotherapy in that mouse model that was pointed out. And so not only is there a strong clinical rationale to use this in the neoadjuvant setting, but there's also a strong scientific rationale. And so we actually first studied the use of neoadjuvant targeted therapy in patients with high-risk resectable melanoma who had a BRAF mutation. And what we wanted to do was we wanted to ask the question that if we actually treated patients before and after surgery with BRAF and MEK inhibitors, we could actually improve relapse-free survival rates over upfront surgery, which was then standard of care. And so we designed this clinical trial for patients with bulky stage 3 melanoma, if they had a BRAF mutation, and randomized those patients in a 1-to-2 ratio to either undergo treatment with then standard of care upfront surgery with standard of care adjuvant therapy versus treatment with neoadjuvant and adjuvant BRAF and MEK inhibitors. And what we did is we treated those patients for 8 weeks, restaged, and then treated them in the adjuvant setting. Importantly, and I think as Suzanne and Caroline have pointed out, I think an important component of these trials is not just to measure clinical endpoints, but also to do, this offers the opportunity to do deep correlative studies, and we did that as well. And so we actually opened this trial and actually stopped this about a quarter of the way in because the very strong signal with regard to differences between the upfront surgery arm and those patients who were treated with neoadjuvant and adjuvant BRAF and MEK inhibitors. Nonetheless, we were able to get some very useful data from this small cohort, and what we found is that treatment with neoadjuvant and adjuvant BRAF and MEK inhibitors was associated with a high RECIST response rate on first restaging after 8 weeks of therapy. So there was 85% of patients had a bona fide RECIST response. And in addition to that, there was a very high pathologic complete response. We actually saw a path-CR rate of 58% in this cohort. So over half of patients who were treated just with 8 weeks of neoadjuvant BRAF and MEK inhibitors had no viable tumor at time of surgery. Now, how did this relate to actual relapse-free survival? And so we looked at the probability of event-free survival in either neoadjuvant and adjuvant BRAF and MEK inhibitors in the blue line compared to upfront surgery as standard of care. Again, very, very striking result, namely patients, if they have a BRAF mutation in bulky stage 3 melanoma, they clearly benefit from getting treated in the neoadjuvant and adjuvant setting. Now, what's the relationship with the pathologic complete response? And we published this in Lancet Oncology, about a year or two ago, and showed that if patients have a pathologic complete response, they actually have very strong long-term benefit. And really want to give a shout out to Rhoda Amaria, who really led these studies. And now, importantly, these correlative studies in the context of these trials are really critically important. And so we did deep molecular and immune analysis in longitudinal samples from these trials, and we found that we could actually identify potential predictors or targets of therapeutic resistance. When we looked at whole exome sequencing, we found that if patients who failed to achieve a path-CR had a higher frequency of known resistance-conferring mutations that activated MAP kinase pathway. Not a shocker, but you could actually find these in the pretreatment samples. And furthermore, when we did immune profiling in these tumors, we found that if patients failed to achieve a path-CR, they actually had equal numbers of infiltrating T cells, but the T cells in the patients who failed to achieve a path-CR were completely exhausted. Now, we next, after closing down that arm of the trial, we next amended the trial design to evaluate the impact of pathologic complete response on relapse-free survival and open this at additional centers. This is now open at MGH also. And so essentially we keep that same single-arm study now where we're looking at neoadjuvant BRAF and MEK inhibitors for 8 weeks. We do re-imaging, do surgical resection, and treat in the adjuvant setting. And again, we see a very high RECIST response rate. Again, very high pathologic complete response rate, a little bit lower than in the initial cohort. Interestingly, the radiographic responses don't always correlate with the pathologic complete response for targeted therapy, whereas with immunotherapy they tend to. And then as far as the data, again, I think very compelling. And if you look at the relapse-free survival curves in patients who achieve a path-CR on targeted therapy, they're actually quite good as opposed to those who don't, which does have a hint here that gosh, patients who are not achieving a path-CR on this may just need something else. And then this also correlates, again, this is very early data, but also correlates or goes along the lines with DMFS as well as overall survival. Now, interestingly, what's the site of recurrence? And so, interestingly, we're seeing a lot of CNS metastases and with this targeted, neoadjuvant targeted therapy, and even in patients who achieve a path-CR, much lower than in patients who don't, but nonetheless, I think this is something that we can learn from. Now, importantly, other groups have run these neoadjuvant targeted therapy trials with similar results. This is Georgina's study that she published in Lancet Oncology, where she and others ran a neoadjuvant BRAF and MEK trial for 12 weeks, restaged, did surgery, and then completed a year of therapy. And what they found was a RECIST response rate of 86% with a path-CR rate of around 49%. And when they actually looked overall, again, the curves were very similar to ours. You know, there's clear benefit, but when you break it down into patients who have a path-CR versus don't, it's not quite as clear in this cohort. Furthermore, they did deep translational studies, which again kind of highlight the importance of the immune cell infiltrate as well as the proliferative status of the melanoma. Now, Caroline covered the immunotherapy, but I also thought I'd mention our study just a little bit again. We not only studied targeted therapy, but also studied the use of neoadjuvant immune checkpoint blockade. Caroline has gone over this already, but again, run by Rhoda Maria, outstanding medical oncologist at MD Anderson, and randomized patients to either receive combined ipilimumab and nivolumab compared to nivolumab alone. And you saw the data already. We actually stopped this trial as well early because of the toxicity component. And again, we saw that with PD-1 monotherapy, there were patients, about 25% of patients had a pathologic complete response, but there were patients who progressed on therapy who did not go to surgery. You triple the RECIST response rate and nearly double the path-CR rate with combined therapy, but at the cost of toxicity. And, again, the survival curves are as published in Nature Medicine. But I think now we've learned from Christian and others what could be the optimal dose. And interestingly, Suzanne and Janice, we also saw these B cells and tertiary lymphoid structures in responders. And so, we can learn a whole lot from these translational studies in the context of these neoadjuvant trials. Now, importantly, we are all working together as a team on this. We've learned from the breast cancer community, and we have established this international neoadjuvant melanoma consortia with over 240 international members. We actually, what our goals are to, make consistent trial design across international sites, to align translational plans. And now we've actually published, as a group, a very collaborative group, have actually published 2 papers. One, a pathology paper, really kind of guiding how we should be looking at these specimens, as well as a white paper on potential ways that we could use neoadjuvant therapy in melanoma. Now, this does include efforts to aggregate all available data to assess, the potential efficacy of regimens. And so this was data that was presented by Alex Menzies from the MIA, and he presented this at ASCO, and essentially aggregated several clinical trials and looked at the duration of therapy and also looked at responses. And what they found was that when you compare, and again, I love both targeted therapy and immunotherapy, so I hate to compare them, but if you do compare them, you see that patients who were treated with neoadjuvant immunotherapy tend to have better outcomes overall. And then if you break that down into those who achieve a path-CR versus those who don't, again, you kind of see those same signals. Whereas if patients achieve a path-CR on both, they actually do pretty well. But even the ones who don't achieve a path-CR on immunotherapy still do pretty well. Again, we need to follow this data out, but I think, there's real power there. Now, I think in my last minute, just wanted to better, kind of stimulate a little discussion on how we can further improve responses. Certainly, I think, we know, and Keith and I did this work together, is we know that oncogenic mutations like BRAF can actually drive, immunosuppression. And if you block them, you can make tumors more immunogenic. So can you actually combine these therapies? And there were studies that were recently published in Nature Medicine suggesting the efficacy of combining BRAF-targeted therapy and immune checkpoint blockade in patients with stage 4 disease. We should be using this in the neoadjuvant settings as well, and that's already being planned. In addition to that, here's a unpublished data, which is kind of fun. What's the role of gender and sex hormones on cancer and therapy response? Are boys equal to girls? Well, what we found, and again, we know from overall incidence of cancer, it's much more frequent in males. There's actually, these should be taken into account when we're looking at differences in therapeutic responses. And lo and behold, in our neoadjuvant targeted therapy trial, what we found is that patients who were female did much better and were much more likely to have pathologic complete responses. We actually took that back to a mouse model, put female melanoma tumor cells into male and female mice, treated them with dabrafenib and trametinib, males did worse and actually blocked sex hormones and cured all the mice. So pretty amazing story. But I think others have seen this, and something to keep your eye on. So I think treatment with neoadjuvant targeted therapy is associated with high RECIST response rates and high path-CR rates. However, achieving a path-CR is candidly, I think, and again, will be argued, I'm sure, a good surrogate for long-term benefit. But I think patients who achieve a path-CR on targeted therapy can still relapse, and I think that's something we need to grapple with. I think as we move forward, we really need to work as a team, kind of take the lead from the breast cancer community and have a real team science approach, and there's still a tremendous amount to learn, and we definitely owe this to our patients. So I wanted to thank everyone, and again, thanks Suzanne and the MRA and the FDA for this opportunity, and also the International Neoadjuvant Melanoma Consortia. Thanks.
Hey everyone, my name is Janice Taub. I am a pathologist, specifically a dermatopathologist at Johns Hopkins. I am going to talk about the assessment of pathologic complete response and major pathologic response, what's sometimes been referred to in the melanoma group as a near path CR. So this has obviously been discussed as an endpoint, and I want to get into some of the details in terms of how this is assessed, both in terms of immunotherapy and targeted therapies in this setting. So first, to make sure we're all aligned with regard to definitions, pathologic complete response is, of course, no residual viable tumor, whereas major pathologic response, that's a term that was first recognized in the lung cancer literature as less than 10% residual viable tumor. And again, sometimes in the melanoma literature, it's referred to as near path CR. But there are additional provisional terms that have been floated, a partial pathologic response, meaning less than 50% residual viable tumor, and a pathologic non-response being above that cut point. I think it is important to acknowledge at the outset that we don't know the biologic import of that cut point. Right now, that's something that we expect to be able to test over time. So how do you actually assess percent residual viable tumor, right? So the numerator is, of course, how much surface area is involved by tumor, but the real question is, what's the denominator, right? Where did the tumor used to be? And I think, there's been a lot of discussion today in terms of the different mechanisms of chemotherapy and immunotherapy. There's also different histologies potentially between these. So when you're looking at chemotherapy, you tend to see, if you will, death and destruction of the tumor in place in its original footprint. And when we first looked at Patrick Ford's specimens from the anti-PD-1 lung cancer neoadjuvant trial, what was notable to us is there actually seemed to be an outside-in shrinkage of the tumor. So the residual viable tumor here is within the blue bounds, and where the tumor used to be is actually shown within the green line. How do we know this for sure? Well, we went back and we carefully looked at the radiographic size of the tumor, the gross specimen size, and what you're seeing next to the radiography is the lung cancer specimen that's now been sectioned and measured. And then we correlated that with what we were seeing on histology in those green bounds. And so, this has really important implications if you start to look at thresholds beyond simply pathologic complete response. Again, where did that tumor used to be? So if you look within the blue bounds, for those who aren't used to looking at pathology, the big pink cells are the tumor, and the smaller ink spot cells are your immune infiltrate, but we would grade within the blue bounds as 80% residual viable tumor. But if you actually recognize correctly that your denominator should be the green line where the tumor used to be, there's actually a big difference. And so there's 40% residual viable tumor in that instance. I think that there's a lot to learn in terms of the immunoarchitecture of immune-mediated regression by very carefully looking at what is in that area where the tumor used to be, or what we're calling the regression bed. And so we saw markers of immune activation, which is not overly surprising, right? Tumor infiltrating lymphocytes, which we expected to see. There were notably tertiary lymphoid structures in a number of cases, as well as plasma cells. And those latter two factors really infer that there's an organized B cell response to tumor that's ongoing. we saw a lot of features of cell death. So cell membranes are, of course, made up of lipids. And when you have massive cell death, you have macrophages that come in to clean it up, and it gives them a foamy look to the cytoplasm. We saw a lot of those. There actually was so much cell death that you got extracellular deposition of lipid, and we call cholesterol clefts in the tumor. But probably one of the features that was most striking was the fact that we saw features of tissue repair. So the body's coming in and trying to heal itself after the tumor has resolved, same as you would with any other wound that was then healing itself. And so we really went through this, as I mentioned, in Patrick Ford's cases. So in addition to characterizing comparisons to the radiology and responders versus non-responders, we also did a very careful comparison between all the histologic features from pre-treatment specimens to the on-treatment specimens. And that really allowed us to associate the changes that we were seeing with exposure to therapy. As Jen alluded to, there's a very collaborative working group through the INMC, and I was delighted to be invited to work with Mike Tetzlaff, Richard Scoyer, and others to look at some of the histologic features of immune-mediated regression in melanoma around the time that we had just finished characterizing lung. And lo and behold, we actually saw the same constellation of histologic features when we were looking in melanoma. So again, some of the features we saw were the neovascularization and the proliferative fibrosis, that wound healing signature, as well as plasma cells. We also saw the foamy macrophages and cholesterol clefts. The foamy macrophages in melanoma often take this look of melanophages because there's a lot of melanin around that they are cleaning up. But again, the same constellation of features was associated with responders in patients who had received immunotherapy with melanoma. And so we published these back to back in the Annals of Oncology. One important piece about the lung data is that we also did an inter-reader agreement assessment. So once we defined the features, we found 5 pathologists who were not involved in developing the features. And we actually asked their inter-reader assessment at 10% threshold. So not just looking at path-CR or even major pathologic response, but how good were they at 20%, 40%, 50%, and so on. And that really gets to the point of maybe we can examine other cut points. But to do that, you would certainly need reproducibility amongst your pathologists. And we were able to achieve that by very specifically delineating which features we were looking for. So, right, how do these features associate with patient outcomes? So Tara Mitchell's study was shown before. What I think was important about that study is that, again, it looked at not just the pathologic complete response point, but also near path CR for long-term survivals. And getting, again, to that mechanism of immunotherapy, do we really need to achieve path CR to have a good patient benefit? Perhaps by the time you've been diagnosed, you receive 2 doses of immunotherapy, and then you go on to surgical resection. Maybe if your tumor has shrunk by 2/3 by that point, you have sufficiently primed your immune system to be able to surveil for you in the future. And so to that end, this relapse-free survival published by Christian Blank and his group shows not just path CR, but near path CR and so-called partial pathologic response as having a good relapse-free survival at the 18-month time point. We wanted to actually look out longer than that and see, how could we tie these features that we were looking at assessing now to overall survival with longer follow-up. And again, these data are not yet available from neoadjuvant cohorts. We simply have to wait for them to mature. But we wondered, could we get ahead of this by looking at patients with advanced disease? And so what we did then was assess pathologic response using those same features on biopsy. And we're calling this MPR-BX, with the idea that you could look for 10% residual viable tumor in the context of, again, the appropriate regression bed to be able to assess for those features. And so this is what that would look like. You can see the edge of the specimen on here. This is a needle biopsy. Same features we talked about before: proliferative fibrosis, inflammation, plasma cells are shown here and highlighted. And in fact, we then took it in partnership with Bristol-Myers Squibb and looked at their 038 cohort. So there were 51 biopsies from patients who had been biopsied in a very regular fashion, so 4 weeks after receiving anti-PD-1 therapy. And those patients who had a major pathologic response or a complete pathologic response on biopsy at that time point had excellent overall survival at the 5-year time point. And we then looked at a second validation cohort for these features. Again, this is performed on an incisional biopsy and was predictive of overall survival in the advanced disease setting. So I think this is really encouraging to say that we are on the right track with the features that we are looking at. Scientifically, it's also good to know that immune-mediated tumor regression looks at immune-mediated. It looks the same whether you're at a primary tumor in a lymph node or the liver, and I think that there's a lot for us to learn in terms of translational value there. Bless you. Shifting gears to targeted therapy. Right now, there's a number of ongoing analyses that are associated with that. I know Mike Tetzlaff and Richard Scoyer are really leading these. Dr. Wargo alluded to the fact that there is disease progression often in the CNS following pathologic so-called response. And so what those two are looking at is whether there are specific histologic features that would then allow them to predict that response. They're also following in the work that we did with immunotherapy and looking to see whether early on treatment biopsies are representative of the eventual resection specimen. So we're looking forward to seeing that report in short order. So in conclusion, I think it's important to note that histologic features of immune-mediated pathologic response in early on-treatment specimens do associate with long-term patient outcomes. I think the relapse-free survival data for patients with immunotherapy lend support to the idea that they will also be predictive of overall survival in the neoadjuvant setting. We're certainly very interested in looking at clinically meaningful thresholds beyond path CR, whether it is MPR or 50% or 20% or so on. And definitely the work ongoing about refining histologic features of response for patients treated with targeted therapies. I will leave you with one last thought. I started with showing how our observations in lung really informed how we interpreted the biopsies from melanoma. And we also talked about how the features of immune response look different irrespective of the site that was biopsied and the stage of disease. We think that it might be possible to actually develop a pan-tumor scoring system for pathologic response. So we have now reviewed over 500 on-treatment specimens from more than 10 different tumor types from regimens that contain either anti-PD-1 or PD-L1. And those trials are listed here. The top block is in the neoadjuvant setting, and the bottom block is an advanced unresectable disease. But we are seeing consistent histologic features of response across these examined specimens. And actually later today in this room, once this ends, SITC has sponsored a meeting from 2:15 to 3:15 to talk about the next steps in developing this scoring system. So I would invite anyone who is interested to also stay around and attend for that meeting. Thank you.
So I'm going to take the moderator's prerogative here first, and just I would just want to correct one glaring omission in terms of my acknowledgments. I just want to acknowledge Suzanne Topalian's efforts with the MRA. Without her leadership in this and input, it wouldn't be the panel and discussion that we're going to have today. So I think also as part of this, we are running a little bit behind, but I believe we could have 1 or 2 questions to clarify, any of the presentations that you had seen or data. We will have 70 minutes for panel discussion later. And this is a great room, great number of people to have really an interactive discussion. That is the hope. So please go ahead.
Hi, I'm Israel Lowy from Regeneron. Can you, maybe I missed it, but are there distinct pathologic features of the responders to the targeted therapy versus the immunotherapy, so that by looking at the biopsy, you can tell, oh, this patient was treated neoadjuvant with BRAF/MEK versus an anti-PD-1 or anti-CTLA-4?
Yeah, so it's a great question, and this is one of the pieces that I know that Michael and Richard are working on. I haven't been as involved in the targeted therapy piece, but yes, the inference is that one may see an immune response also in the targeted therapy setting, but it's often not as well developed, and that there are some distinctive histologic features in the targeted setting that have not been described as associated with response to therapy. One of the ones that they have spent a lot of time discussing, which I think is quite interesting, is the presence of necrosis. And so of all the features that I mentioned related to immunotherapy, you'll note that not one of them was necrosis. And in fact, we have found, and others have reported, that necrosis may be a contraindication to therapeutic response. And yet it's still unclear what that means for targeted therapy. And I think until they publish their work on a comparison between pre and on treatment specimens there, we won't really know that answer.
Okay, Mark, do we have time for one more question? Or okay, one more question.
Just by way of comparison in the breast cancer studies, we are seeing also brain mets in patients who have path-CRs. And, we were attributing it to using drugs that weren't crossing the blood-brain barrier, and that was just going to be a sanctuary site. But you would think that immunotherapies may be different. I think it would be interesting because there are very few of these cases, but they are striking, and there may be opportunities for collaboration there.
Yeah, we saw this primarily in the setting of treatment with targeted therapy, where we see, exactly, in patients who have a path-CR, they can still relapse in the brain. And again, it's something, it's an area that we're investigating further. Haven't really seen that with the neoadjuvant checkpoint blockade, which is reassuring. And so, I think, that at least in early days, I think we still need to follow these patients out, but I think it's more encouraging, at least with the immune checkpoint and immunotherapy. Nonetheless, I always say, I love both. I think combining them is a great strategy. And so, as we develop these trial designs, I think, keeping targeted agents on the table to use in combination is important.
One way we're trying to get at this is to look at circulating cells or circulating DNA to see if that's persisting in these patients. Have you guys done any work in that area?
That's a great question. I think Mike Davis is also looking a lot at this. We're looking at some extracellular vesicles too. I think that's another area in these patients which will be important to study. But yes, absolutely, I think an area of critical need, and could study it across tumor types too.
And also I would like to insist on the fact that it's right now, for example, we don't really know if targeted combination as adjuvant treatment or anti-PD-1. There is always the big question. It has not been compared head-to-head, but if we have the answer, because we have a neoadjuvant treatment with one or the other and we don't have response, I think it will help us a lot to know what adjuvant treatment to give. And also another situation that is not so frequent, but that is very problematic for the patient, is mucosal melanoma, either nasobuccal or genital. These are patients with technically resectable tumors, and historically they had surgery that was really very difficult, disfigurating, or functionally really problematic. And I think we should stop doing that, and we have neoadjuvant treatment for them. And if we cannot do the resection, it means that we should not have done it. So I think we have to think differently also for this kind of patients.
So I'd like to thank all the panelists for their presentations and excellent comments.